Okay, welcome, a warm welcome on this cold. No, I'm still looking at rain. I'm Veronica Williams, and I have the honor to serve as the president of the Willamette Women Democrats. Before I make a few remarks, several housekeeping matters. As you have joined us, we have muted your speakers and turned off your videos. We do this to improve the overall quality of the transmission of the program and to help ensure that our speakers will not be interrupted by accidental noises at your end. So unless I specifically call on you, please stay muted with your videos off. Thank you very much. February 7th was the opening day for filing for office for the upcoming May 21 election. As is our practice, we will be inviting candidates for local community college, school board, and other special district positions to introduce themselves. Several are W2D members, and we are thrilled to see them step up and run. We have two outstanding women with us today, and I strongly encourage you to stay for the entire program to meet them and hear why they are running. I assure you, you will be impressed. We entered the second month of 2021 with COVID numbers beginning to decline, but with the fear of the impact of new strains of this virus hanging over us. And at the same time, we have hope as the vaccine becomes available. When we last met, the memory of the attack on our nation's capital was fresh in our minds. And today, as the impeachment trial continues in Washington, D.C., I'm sure many of you are reliving the horror of that event. Joe Biden and Kamala Harris have been sworn in and are beginning to go about the business of restoring the executive branch of our government and of governing. We thought 2020 was a challenge, but challenges clearly continue into 2021. Hang in there, everyone. It is still a bouncy ride, but I must admit, I do wake up calmer every morning. About 8 or 9 months ago, our board began talking about a program on public health, and our lived experiences since then make it even more relevant. I wish to thank board members Claudia Black and Leslie McBride for their work to bring two outstanding speakers to you this afternoon. Following their initial presentation, we will pause to introduce elected officials and candidates that have joined us in the Zoom room. And at that time, you can enter your questions in the chat, and then we will have a Q&A with our two speakers. And now I will hand it over to Leslie McBride to introduce our speakers. Leslie?
Thank you, Veronica. And thanks to everyone who has joined us for today's program, Public Health Under the Radar Until COVID-19 Hits, or maybe that strikes. It's my great pleasure to introduce our two speakers today. So let's begin. Paul Lewis, our first speaker, is a pediatrician and infectious disease consultant at Kaiser Permanente Northwest and OHSU. Since 2004, he has served in a variety of state and local government roles, including Multnomah County Health Officer from 2014 until January 2020. Dr. Lewis landed in Oregon in 1996, joining the OHSU pediatric faculty after an educational odyssey from Detroit to New Haven, Palo Alto, San Francisco, Salt Lake City, and Seattle. After setting up a virology laboratory and launching the region's first pediatric HIV clinic, in 1997, OHSU thrust him, now those are Paul's own words, into the hospital epidemiologist position. This unexpected pivot led him to population health and ultimately to joining the Oregon Public Health Division in 2004, where, following the events of 9/11, he worked on bioterrorism before leading Oregon's original pandemic influenza planning. Subsequently, he served as health officer in Clackamas, Washington, and Multnomah counties, where he focused on reducing drug overdose deaths, advocating for homeless health, and improving physician communication. Recently, he launched a virtual clinical rotation for medical students that does outreach to Oregon Health Plan members. In this rotation, students and faculty learn together about social determinants of health, health disparities, and developmental origins of disease, using the COVID-19 pandemic and the events of summer 2020 as contemporary examples. Dr. Lewis has been in continuous hospital-based pediatric practice for 33 plus years and is board certified in preventive medicine, general pediatrics, and pediatric infectious diseases. He also holds a Master of Public Health degree. Dr. Lewis and his wife, obstetrician Ann Scott, live in Southeast Portland, where they nurture 3 teenagers, a variety of animals, fruit trees, and partially completed projects. Our second speaker today is Rachael Banks. As director of the Oregon Health Authority's Public Health Division, Rachael Banks is responsible for expanding OHA initiatives, including public health modernization, the State Health Improvement Plan, climate and health, immunizations, opioid prevention, and clean air and water. She's also responsible for helping OHA achieve its goal of eliminating health inequities by 2030. In her previous position as director of Multnomah County Health Department, Ms. Banks led the county's response to the COVID-19 pandemic, a role that involved developing policies, securing resources, and mobilizing the division's workforce. Advocating for health equity has been a major focus of Ms. Banks' career. She helped develop Multnomah County's first disparity-focused community health improvement plan, and she has advocated for an increased focus on equity, epidemiology, and community partnerships in Oregon's public health system. Ms. Banks earned her bachelor's degree in psychology from Gonzaga University and her master's degree in public administration from Portland State University. Paul and Rachael, thank you so much for joining us today.
So say something if you can hear me.
We can hear you.
All right, and then say something if you can see something.
We can.
We can see. Do you want to just click on the slide? Yeah,
There we
there.
go.
Excellent.
Okay, so so first of all, hi to Rachael. Rachael and I shared an office wall not that long ago. We both moved on. Anyway, and Claudia, I tried to honor her and when I left Multnomah County for her mentorship. So when she made this pitch, I said, there's this great picture of the last case of polio in the Western Hemisphere, and that's what I'm gonna lead off with. And I actually couldn't find the picture that I remembered. This is the last child known to have polio in the Americas. It was 1991. The picture that I remember was actually of this boy walking away, just seeing him from behind, holding a parent. He was smaller than, holding a parent's hand in each of his hands with an obvious limp. And if you follow this sort of thing, you know that it's almost gone. But other factors that we'll touch on, and I know Rachael will touch on, have profound influence beyond the technology on local, national, and global health. So, I just called this 3 millennia vaccines. I don't know why. And the exemplar is this horrible disease called smallpox. I'm old enough to have a scar on my arm from when I was inoculated against smallpox. And the reason did someone say something?
Go ahead, you're fine.
Okay. The reason we care so much about smallpox is that it was really, really contagious, like a lot more than COVID. It was a miserable, disfiguring illness, and 1 in 3 people who got it died. So it was, really, really horrific thing. And it was a scourge for millennia. Mr. Ramsey's over here got mummified and has scars. I don't know if you could see it on your screens there on the side of the face. So going back, to the pre-modern era. And then I'm not going to spend too much time on this, but I want to make the point. This could be a lecture discussion unto itself, is that there's an estimate that prior to around 1492, there were 150 million Native Americans. But by the time sort of the larger waves of colonists arrived, there was about 1 million. So about a 99% death rate in the post-Columbian era. And it was felt to largely be due to smallpox. And because of founder effects and migration, there was the death rate was not 30%, it was about 99% in native populations. And again, smallpox is this good example because the last case on the planet was in 1975, and it really, really, really does seem to be gone. Now, if you ask the CDC what happened to get rid of smallpox, they kind of take, might I say it, a white male perspective on history. And I headline Mr. Jenner here, who was an English physician. It was in the 17 somethings, and it was before the germ theory. But he didn't discover it, but he learned from women, of course, the so-called milkmaids, that they never seemed to get smallpox, but they did get these problems on their fingers, and it was a relative of smallpox. And he probably gets some credit for putting 2 and 2 together. What follows is not that pretty, really, in that this little boy is getting kind of poked with this stuff and is going to get a big blister and scar on his arm. But then what Jenner did next would not exactly pass Leslie's Institutional Review Board standards now, in that he came back months later and exposed the kid deliberately to real smallpox. And proved that he didn't get it. But again, a little sketchy. That's kind of the white male version of the history of smallpox vaccination. But as you can imagine, there's maybe more to the story, since this is such a bad disease and it's been around for so long. And there's certainly inscriptions and writings from before the Common Era period from China, with the depictions of smallpox and potentially of a prevention of it, well documented in the 1600s in India. And before Jenner was even born, this lady, Mary Wortley, was assigned with her family to a outpost in Turkey and learned there about smallpox vaccination and had her child vaccinated against smallpox. And then, later Jenner went along and did this human challenge thing and kind of takes the credit. But I think that's probably a little bit misplaced. So I'm going to wrap up here quite quickly, but vaccines educate the immune system. And the really important thing to understand about vaccines, because people argue a lot about vaccines and what they do and they don't do, they can completely prevent disease from occurring at all, or they can make it so mild that it's essentially harmless. And one of the many, many debates about COVID-19 right now is whether it does A or B. We will eventually figure that out. So I stole this from the Brits, how do vaccines work? And again, it's a big group. My guess, unless you've been living under a rock for the last year, you probably have seen lots of graphics on vaccine. But it basically educates your immune system by exposing you, typically through an injection, but sometimes through something you swallow or inhale, a small amount of something that's harmless, but educates your immune system about the more harmful version of it. Then if you're exposed to it, you really don't even know, because your body has this head start. and it prevents the illness from even getting started. So truly remarkable. And among the truly remarkable things is, I'm guessing there are a couple of people on this call that might remember the last mass vaccination effort we had for polio that began in the 50s. I collect friends, and I collected 3 physician friends here in Oregon, a little bit older than me, that are all polio survivors with 3 degrees of disability. One walks and talks and you wouldn't know it unless you knew him well and knew how sore he got sometimes at the end of a long day. Another guy uses double canes, and the third one's wheelchair bound. And again, these are folks that are in their 60s and 70s now, and they've been that way for half a century. I put the picture from Africa over on the right as a sort of a sobering reminder that 70 years after this disease could have been eradicated, it still isn't. And it's not because the vaccine doesn't work. It's because of the complexities of administering vaccines, difficult parts of the country, war, strife, inequity, et cetera. This has been on the hit list for about 30 years now, and we keep getting really, really close at not eliminating it. And then finally, just a little travel log here. Measles, bottom left, again, something that could have been eliminated. We keep getting close, and now it's sort of firmly reestablished itself. When I was training to be a doctor, all the babies had meningitis, and now it's sort of so rare that if there's a kid with meningitis, you have to get the students to go see it in case they never see it again. And then, tetanus, again, a disease that should be completely eliminated. There was a really well publicized case here in Oregon about 3 years ago. Again, all these are completely preventable. The challenges I've kind of touched on. You probably know that some bugs just resist our science, tuberculosis, HIV, and malaria being pretty high on that list. And then COVID and flu are showing us, we knew that flu could be a shapeshifter, and now COVID is messing with us with these new variants and concerns about the vaccine. But as important as the biology is, I think the social factors having to do with equity and distribution with COVID, what countries are even going to get the vaccine. Cost is always an issue. In other parts of the world, and even in our own backyard, we have issues with ideology. We have civil unrest places around the globe. And I think the thing that I suspect just from your early remarks is trust in science, trust in government is a little tenuous right now. And launching a vaccination campaign is all that much harder because of that. So I'm gonna stop there and turn it over to Rachel, because I think that the stuff that you're most interested in has to do with our state and nation's efforts to try to put a lid on COVID-19. Rachel?
Yeah, thanks, Paul. I always love listening to Paul's lectures. Now I'm thinking I should have said, no, I'm not going to speak. I just want to listen to Paul. Please invite me. I'll come, I'll register, and I'll get a history lesson and always great photos and just an enthralling presentation. As you were talking, it was just such a good foundation in terms of talking about public health. I think vaccines are so core to public health work. People talk about it as being the bread and butter of public health work, and as has been and maybe under the radar for so many times, as the title suggests, because many of our vaccines have been in development for some time, and we have systems, well-oiled machines. I was just meeting with the immunization planning team unit today at Oregon Health Authority. Big shout out to them and their longevity. I mean, there are people who've worked there for 30 years, many people over a decade. So this, work has been happening phenomenally in Oregon with a great group of people. And now we're in this mass vaccination for COVID-19 that has all of the elements, like Paul said. I mean, I'll just start today with giving you a little bit about where we are in our vaccine implementation, really laying out the overlap that we see with vaccine and health inequities and what we're seeing play out here right in front of our very eyes. ultimately want to, of course, talk about a needed public health system and public health modernization, and how we've used current legislative, or former legislative investments in our public health system, and what we plan to do if we have additional investments this legislative session from public health modernization. And then just touch on, as Paul talked about with those challenges, that it's not just the vaccine that's going to get us out of COVID-19 or anything. It's actually getting people vaccinated, and that has a variety of different factors in it. So I will say at this point, Oregon has vaccinated over 600, has given over 620,000 vaccinations. We are moving, we have several populations that we have been vaccinating, including 1A, which as many folks probably know is our healthcare worker population. We define that extremely broadly for a number of reasons, taking into consideration the setting exposures that might be for licensed professionals, as well as those folks who are working in environmental services, or those folks who are providing food or other sorts of care in health settings. We wanted to make sure that we got healthcare interpreters, traditional health workers, and any other folks who are involved in the healthcare, as well as our friends and neighbors with intellectual or developmental disabilities that may be receiving health care in their home or other settings. So that population has been underway for a while. As folks know, we've moved through largely through the education and childcare workforce, and just this week, I guess, opened up for seniors and elders 80 plus. Over the next several weeks, we are going to be moving through each week, opening eligibility for another group, another age band, if you will, going down to 75 and so on and so forth, until we get to our 65 and over population. And then ultimately we'll be moving to 1B, which has been defined by the Vaccine Advisory Committee, and we're working through operationalizing their recommendations as well. I think, one of the things to draw out is in terms of equity, and what we're seeing in terms of the data of who's been vaccinated. It's not matching our population demographics, but I don't even think that that's a good enough marker. The marker is really if we look at who is having cases, but more importantly, I would say hospitalizations and unfortunately deaths. That's really where I would want to see those percentages match. We have seen egregious inequities, for example, in the Pacific Islander community, the Latino, Latina, Latinx community, many communities of color, Native American communities as well, Black communities. And that was really the focus of the Vaccine Advisory Committee as they talked about how do we get vaccine out, is, with a vaccine that's shown effectiveness to decrease the severity of illness and or death, how do we pair that vaccine with who we see are having worse outcomes? Clearly, we also, that's the reason we wanted to start with, I should have mentioned in 1A, long-term care facilities, that we've been through that vaccination as well. So we, don't have enough vaccine for everyone that needs it and would like it. And I think that primarily is one of the reasons it makes it an equity issue, and we're watching it play out in full time. So our goal is we want to get more parity, if you will, in that vaccine distribution. And I think there's a number of factors that go into that. Part of it, but it's not in my mind a sufficient explanation, is who is what are the demographics of workforces and in Oregon. And we know that for our healthcare workforce, for example, or our some of our educator workforce, that we may have less diversity in that workforce than we see in the general population, or less than what we see mirrored in our statistics. But I think, really what the charge is for Oregon Health Authority is to completely eliminate health inequities in 10 years. And I'd like to say all of us is to continue to look at those numbers and look at the demographics and say, are we doing a good enough job here? And because of the reasons Paul talked about, ideology, trust, history with healthcare systems, differential access, lack of language access, there's a variety of reasons. We need to focus more specifically on communities that we know have been left out. I'll say one thing kind of before giving a couple thoughts to wrap up. I've had many conversations over the course of working in public health about health inequities. And, you know, those equity practitioners will always raise that health inequities are avoidable. They are unjust. They don't have to be this way. And I think that goes against a tendency that we have, particularly with an inequity that's long-standing. And so you know, we have inequities in diabetes or chronic disease, heart disease, that sort of thing. I worked for a long time working on those disparities and the inequities in the Black community. And I think in some ways it was easy enough for people to go, well, yeah, but that disparity, that inequity really started a long time ago. It started with behaviors, that's a chronic disease. It started a long time ago. What are we going to do about it now? And we have all watched an inequity play out right before our eyes. And it didn't even take a year. We were watching at month 3. We were looking at our Latinx rates, month 4, month 5, and we have watched that this isn't about, you know, it's about structural racism, and it's about the way that the benefits and burdens of society are set up. The folks who have been exposed are exposed as a result, and particularly as we watch this play out early in the pandemic, as a result of where they lived, if that was in a congregate care setting, for example, where they worked, whether that was in healthcare settings or other long-term care facilities or other food manufacturing and farm workers and all of those things, if they lived in households with a variety of people. So these weren't functions of just you know, people's behaviors and if they ate too many chocolate bars, right? This is a function of what you have to do to live and to meet your basic needs. And so, you know, that's just one thing that we can prevent these inequities. And I'm particularly excited to talk to you all, because what we know about a modernized public health system and is that, and Oregon, I think, to my knowledge, is the only state who has modernized its public health system through legislation and through working with the legislature. So big shout out to anyone who's been involved in public health modernization efforts. This year, the governor's budget has an additional $30 million in her proposed budget for public health modernization. The last investments focused on a couple of things, and I could not be more thankful that the legislature and Oregon Health Authority and other colleagues had this foresight. It focused on communicable disease and preparing us for emerging infections, and it focused on assessment and epidemiology and health equity, which clearly we want to continue to be able to do. But in this modernized public health system, we are using core capabilities like policy. We've seen that in COVID play out in a number of our strategies. The reasons, arguably, that Oregon is consistently in under the least 5 states, I'm saying it backwards, the best 5 states, I guess you could say, in terms of cases and deaths for our elders. Like, I would argue that a lot of this has to do with those policy and systems approaches. It has to do with how we've used our assessment and epidemiology. So these are all for our as public health wonks, core public health capabilities that we say you have to have those foundationally strong, no matter what disease you're working on, no matter what. And so I would just kind of end with that and tie it in with one other example of a modernized public health system, and particularly focusing on equity and something like vaccine hesitancy. Many communities, for a variety of reasons, have had bad experiences or don't trust this vaccine or other vaccines, and we've seen increasing conversations in our state about that. And the thing is, it's very different for different communities. So we have to have a public health system that can get nuanced enough, can get culturally specific enough, can be working in a variety of settings with stakeholders, faith-based, culturally based, to be able to understand it and work with communities. And I think that is one of the things I most enjoy about having conversations about public health modernization and how our public health system works, where we have tribes and local public health authorities. And now we funded over 170 community-based organizations. and the state public health system. And that really, in order for us to decrease those health inequities, we need to all be working together. So once again, I appreciate this. I could talk about public health all day. I will not. I know there's a lot of other exciting things that you all have. I'm happy to take any questions or comments when the time is right.
I got to get to my video back on. Thank you very much. I can't get back on. Okay, you're going to have to listen to me. I can't get my video working right now. So I want to take a moment to recognize some people who are joining us. And if you are an elected official or if you are a candidate, please feel free to turn your video on and your microphone and say hello when I introduce you. And then, as I mentioned before, we do have 2 candidates with us and we'll be hearing from them a little later. Meanwhile, those of you who have questions, if you want to put them in the chat, please do so. I have a couple questions from our committee that we'll probably start off with, but then I'll be looking at the chat for additional questions. So the chats, for most of you, if you're on a computer, is located kind of in the center at the bottom of your screen, and you can just type something in there. So right now, I would like to recognize, first of all, we are so pleased to have Margaret Doherty, former state representative, with us now in her I'm retired capacity. But we're very happy to have you with us, Margaret. If you want to say hello, that'd be great.
No, that's okay.
Go ahead. Thank you. And then also with us today are Jules Walters, who is the mayor of West Lynn. Welcome, Jules.
Thank you. Thank you for having me.
Joe Buck, who is the mayor of Lake Oswego. Welcome, Joe. And then Bridget Brooks, city councilor in Tualatin.
Hey, everybody. Nice to see you guys.
And then candidates, Lori Cremona-Wagner, who's going to be running for Portland Community College Board. Hi, Lori. And also Dr. Karen Perez de Silva, who will be running for the Beaverton School Board. And we will hear from Karen and Lori a little later. Karen, you want to say hello?
Yes. Hola, buenas tardes. Good afternoon, everybody. Nice to see you, or at least see your names.
Thank you very much. So we'll get on to our questions. And so the first question is, from your perspectives, what remaining hurdles does Oregon's rollout face? And what can be done to address those hurdles? So I don't know who wants to answer first, but Rachel or Paul? Do we need to, there we go.
You know, I'm a little biased because I'm a pediatrician, and I'm very concerned about the variants because it's likely that the current vaccines will be at least a little less effective. And for reasons that are complex, none of the vaccines have been tested in children, but there's a lot of children out there. And that's gonna, I think that decision not to do that testing may come back to haunt us. So those are the things that are worrying me. In addition to the supply, and again, Rachel points it out. This is happening. That's why I'm teaching this class. This is happening in real time. We just have these permanent problems with health outcomes and health access.
Rachel, did you want to add something?
Yeah, thanks for that, Paul. I mean, I think the hurdles are, you know, we ultimately don't have, it's a classic supply issue. We don't have enough vaccines for everyone that wants them. And I think there's more information to, as Paul alluded to earlier, in terms of understanding with this vaccine, its role potentially in transmission or just making symptoms more mild, and then what that means for our policy strategies and reopening strategies. I think in all of our messaging too, we know that folks are so excited about a vaccine, and we're like, and still please wear your masks and some of these other things. So we want to make sure to continue to do that. And then just the equitable distribution of vaccine is troubling, and wanting to make sure that no matter where we are thinking about those folks who often get left out, whether that's because of mobility issues, language issues, a variety of things. And so those are hurdles to react faster to those things as we're moving through each phase.
Thank you. So I think you're applying, both of you have referenced this, but do you have any opinions about what we can do to streamline the vaccination to especially the populations that have a little more difficulty getting it right now? I certainly know I have friends who are over 80, and even signing up for a number of these have been a bit of a challenge. They've had to get children to help them do the sign up. So are we learning anything? Are there changes coming to how we streamline it, especially as it rolls out farther into the future?
You know, I think Rachel will have some insight into the vaccination. That's actually getting it to people who need it. With regard to vaccine, the stuff, you know, in the little glass vial, there's tea leaves from Washington and Rockville and Atlanta that the third vaccine is promising, and it's got the advantage that it can be given because of its characteristics in any sort of doctor's office, you know, thing. It doesn't have these complicated requirements that the first two vaccines do. So it would be more supply and much easier to widely distribute. I mean, you could send it to the facility and they could give it when they got around to it. There wouldn't have to be this clockwork regimentation with it. But maybe Rachel can help us with understanding the actual vaccination.
Yeah, I think that's huge, and that does play into the vaccination and how things have rolled out in terms of who could store a vaccine, in terms of just scale and efficiency and all of those things. So I think there's promise to a vaccine that's easier, less finicky, and perhaps even, you know, less doses, so that it makes sense for a variety of different populations. A key to that is getting more diversified vaccine administration sites. So understandably, we started with our big hospitals at first because of the vaccine, and health centers and kind of mass vaccination sites. But as folks have mentioned, there's definitely pros to that in terms of throughput. There's also challenges and tensions to that in terms of the systems, whether that's a technology-based system or mobility issues, having access to transportation. So getting to a place where we have enough vaccine and the right type of vaccine to be working with federally qualified health centers, which we will be rolling out here in the next number of weeks, to providers more largely, to be working with community-based organizations and other organizations that are working with their trusted population, where we can partner with them. Those are some of the vaccination strategies that we found to be most promising in other sorts of intervention and testing and other things that we've done with other public health issues. I appreciate the question.
So we had a question: can we really open schools if children are not vaccinated?
Rachel, I have the dogmatic answer. Do you want to give it?
Nope, pediatrician, it's all you, Doc.
So a couple of things. I have the privilege of being on the governor's medical advisory group. She, I think, needs to be judged by the outcomes, and no governor's getting it right, but we have the lowest death rate and the fewest number of cases and the fewest hospitalizations. We're something like half, Rachel might know, like half the national rate. 400,000 national deaths. We should have 4,000. We barely cracked 2,000. So again, I think the governor's early leadership in March was really kind of definitive for setting the pace. Everyone wants, and her prioritization of educators, as a pediatrician, I support that. There's a long list of things besides reading, writing, and arithmetic that you get at school, especially in early childhood, et cetera. And again, I don't need to list them, but nutrition, social support, psychological support, healthcare, et cetera, et cetera, et cetera. So I think the governor's prioritization of that's appropriate. But the dogma I was talking about is that the CDC in the last 2 weeks has published a number of things that demonstrating that even before vaccine was available, schools could be operated under modified procedures very safely for both the students and the teachers. So I think Governor Brown's approach should work even better with the combination of vaccinated teaching and support staff, plus the safety precautions that are becoming increasingly refined. So Rachel, I don't know if you want to add more to that. I hope I got the state part right.
Yeah, no, it was great. Great answer. I don't have anything to add.
Thank you. We have a question concerned about people who are medically fragile and may not have home health care. So how are we working with those populations? I know that the medically fragile were included in one of the higher level groups. I get confused between 1A and 1B, but they're in one of the two of them. But, is there discussion about outreach to people who simply cannot pick up and travel to get, but are very susceptible?
Yeah, absolutely. And, you're right, it's 1A, and we included the population in 1A for a variety of reasons, including equity reasons, and I think are unique in Oregon in that way. We have had a number of conversations about how to outreach to folks. We've, with different sites, also done, I'm not saying it works for everyone, but just for context of making sure that there's accessibility assessments at the max vaccination sites. We have a phenomenal group of partners who advocate and hold us accountable. With each and every county that is moving through, we have an attestation process for local public health authorities. When they feel like they're moving beyond 1A, we are asking for attestation that they have done outreach and worked with partners, and whether that's their sometimes it's their county level people who are case managers, or a variety of folks who are working with this population. And I can tell you that whereby if that doesn't seem sufficient, or we're hearing concerns, we reach back out to the county and say, we need to see some more here. And then we also know that some counties have held either specific spots or slots and are looking at other strategies for medically fragile folks.
Thank you. Does Oregon have a vaccination policy in regard to the undocumented, or is it just simply if you fall in one of the other categories? So for example, an age category, then that question is just not being asked. How is that handled?
So the way that the system works is self-attestation, and that's been for a variety of categories that we've been through. Sometimes people come in and they have affiliation through a health, their employer or whatnot, but we are not requiring people to show proof of citizenship or ID or any of that at this time.
There's a question about whether pharmacies, I think they probably mean when will the pharmacies begin to meet the needs in rural and coastal communities? Is that the plan, to use pharmacies or local health?
So that we have multi-faceted plans. There are definitely local public health authorities who've been getting vaccines for some time, and some communities that they have different, maybe it's at clinics or they have different plans to distribute them, as well as pharmacy partnerships. Early on, there was pharmacy partnerships that were working with long-term care facilities. And what we're is gearing up now is pharmacy partnerships that could be more in a retail setting. So I think the question of, is that sufficient or accessible for rural communities is a varied one. And it you know, depends. I've heard from some communities that it feels like the pharmacy, either the right, there's not the type of pharmacy that's in the federal partnership in their location, or maybe that there's a distance issue. And I've seen local public health administrators in counties be really thoughtful and you know, really scanning to see where are gaps and trying to plan to fill those gaps.
There was a question that I think I missed earlier, and then I noticed Paul partly answered it, but I don't know if everybody's following the chat, so I'd like to ask it. And that was a question about if there were communities that have been identified as successful practices to influence vaccine deniers, or I'll also call them vaccine resistant people. And Paul, do you want to answer that again, but just not in the chat?
You know, I was taking it more broadly. Again, that the survey results are consistent that certain groups, African Americans being one, are for good reason have less trust. And the quote most frequently comes up is, "I'll get it, but maybe later." And Kareem Abdul-Jabbar, who was a basketball player when I was young, and still holds a bunch of records. There was an op-ed, and I said, I'm going to read Kareem Abdul-Jabbar's op-ed, and he made the case that he was vaccinated, and another one of his former teammates were, that the NBA players, who again are some of the biggest well-known people in our country, it could serve a role for that community. And there's a group some of you might be aware of called Working America. It's the lobbying arm of AFL-CIO. I didn't work with them. I tried to support their work during the election cycle, and they take an approach of, you know, identifying peers to the people you're trying to influence. And I think that's a powerful thing. I'm an old white guy. Why should anyone listen to me? But maybe they listen to someone who looks and talks like them. And I think it's a powerful, it's kind of obvious. Like, I mean, Leslie taught me in public health school. It's like, of course, why would you, you need people who look and talk like the community health workers, people that those are going to be much more influential. So that's my thought.
Yeah, and I really agree. And just some of the work that we've been doing is working with those influential leaders, having listening sessions, really making sure that there are space and time for people to ask questions, to understand this vaccine, to understand some of the particulars, either in terms of, and part of it, I should say, is just acknowledging that we understand why people are hesitant. I think that goes a long way in saying, like, in particular communities, kind of doing that acknowledgement, listening, providing that education, letting people come back a number of times, and trying to understand why the reasons that this vaccine might be, you know, particularly perplexing to folks, and trying to understand, you know, to judge it against, like, how long does it take to make usual vaccines and some of those things. So we've had a number, and are continuing to do a number of sessions with faith leaders, for example. I think Paul is exactly right in terms of word of mouth is huge. And to the point, if we know that we have a population that says, I'm going to wait, then we know that that's their runway. So for us, it's like, if we know that that's the communication strategy for folks, we need to make sure that we have those communities of color getting vaccinated now, so that by the time other folks in their communities' eligibility is up, they've had enough time to see people that look like them get vaccinated. So I think whereby we don't make sure there's good vaccine distribution at every phase of our rollout, we push certain groups' acceptance farther and farther out.
Thank you. I have a question about what is being done in the state regarding post-viral syndromes after COVID.
That's a question I would have to, unless you know, Paul, I'd have to get back to someone on that.
I know through my work at the university that and at Kaiser Permanente that there are so-called pathways where we're trying to identify people that, some people call it long COVID. I assume that's what the questioner is about, that people are not all people are snapping back after the illness. Not a lot is known about that. I can't see everybody's face, but I know some of you, and you may remember 20, 30 years ago, the chronic fatigue syndrome. And there's still, there's more known about that, but it's still incompletely understood why a subgroup of people after an illness failed to snap back. And that chapter hasn't been written. I don't know if there's a formal surveillance system yet, because epidemiology, we need to have what's called a case definition, and things are just pretty squirrely right now. But I think, I'm confident if you look at the state's COVID website and the volume of information being collected and displayed, that this will get captured. I'm just not sure it's mature enough for that yet. But again, we can get back to you. Rachael and Dean can get back to you on that.
Okay, great. We have time for one more question, and I wanted to ask a question about the numbers. So it's a little confusing to know what the real numbers are in terms of how many vaccinations are actually getting into arms. And the reason I say that is it's my understanding, and I could be completely wrong, that there are a number of dosages which are sent to the state, and the state knows what that number is and distributes it. But it's also my understanding that there are dosages going through the VA system and dosages going to the tribes. Do all of those flow through you, or are there actually multi-pronged ways that the vaccine is coming into our state and people are getting vaccinated? And then when we report numbers, does it include all of them, or does it just include the ones that go through OHA?
Yeah, so there are multiple ways that vaccine is coming into the state. So the VA system, and there's places where the federal government is working directly. That's one of them. We had a federal pharmacy partnership that vaccinated long-term care folks. Those were seen in our allocations, and we were making decisions to allocate towards there. The tribes is a multifaceted answer. So tribes in Oregon can get their allocation either from the state or from the federal government. I believe 6 tribes have chosen to get their allocations from the state, and 3 from the federal government. So, I understand why it's confusing. And then I know that people also question, okay, well, there's first doses and second doses. And so how many people is that? So for most of those, we do know how many people have been vaccinated through that. We have different lines of visibility and timing sometimes on that. So there's some differentiation. But I can say that over 620,000 people have been vaccinated. Some of those are second doses as well. And we're, relatively, I feel like making good progress through vaccinating our population.
Well, I want to thank you both very much. It's been very informative. I'm sure I speak for everybody in W2D. And we do record this, so we put it up on our website in case people missed it and have a chance to pick it up. But we all want to thank you for all you and everybody else in this very large system is doing. And thanks for talking about public health and reminding us this forgotten important part of our community that we don't think about until we desperately need it. And I'm really glad to hear from you, and I'm sure everybody else is, that we're starting to see some money flowing back into that system so that we can be prepared as we move forward, because unfortunately, this is probably not our last pandemic. So thank you both very much. At this time, I would like to introduce to everybody Lori Cremona Wagner, who is running for Portland Community College, and give her a couple of minutes to speak. So Lori, let's see if we can get your video turned back on and get you unmuted. If you're there. Okay.
Mute. Okay, did that work?
Perfect. You're there.
Great. Okay, so thank you, Veronica, and the W2D's board for giving me a couple of minutes tonight to talk with you about PCC. I'm Lori Cremona Wagner, and I'm running for the elected board of Portland Community College. And overall, the PCC district is enormous, but I'm running to represent Zone 1, which is like Oswego, Tigard, Tualatin, Sherwood, King City, and a little bit of Beaverton. And right in line with what Rachael and Paul were talking about, the COVID pandemic has not only caused a health crisis, but as everyone knows, it's also caused unemployment claims to reach over 400,000 in Oregon. And there's also been a huge issue in terms of equity there. Or the Oregonians that are currently most impacted, not only by the health crisis, but also the economic downturn, are communities of color, women, younger, less educated, and lower income workers. And education is absolutely key to a faster, more equitable economic recovery. And this is why I'm running for the Portland Community College Board, because PCC is actually the largest higher education institution and college in Oregon, and the economic first responder that is really going to help Oregon recover more quickly from this downturn. This means, though, that we have to accelerate our work to put racial equity and frontline workers at the center of this recovery. We've got to put decision-making and solution building as close to the community as possible and allow our higher education, business, people in the community to partner together to address both the short-term and the long-term economic circumstances that this has created. And most critically, I think we need to increase the awareness of the job possibilities that are coming and the pathways for those who have been traditionally marginalized in our community to energize the potential workforce that hasn't been given the support required to enter, and also to succeed in the workforce development and higher learning opportunities that are available. So as one of only 2 women in my college engineering program and the only woman in my first job at a construction company, I know firsthand the challenges of many women pursuing an education and career in STEM, and the struggles of balancing family needs with career pursuits. And also, as a former statistics professor, I learned how the growth mindset of faculty and employees can change the lives of first generation and students who are struggling. At PCC right now, I actually co-chair the Business Advisory Council with Daniel Nguyen, our Lake Oswego City Councilor, that connects the needs of business and industry with students through curriculum development and internship programs. And so understand very well the gap in community awareness of critical industry needs, especially cybersecurity and healthcare, like we just talked about. I'm a member of Oregon's Workforce and Talent Development Board. I was appointed by Governor Brown, and we recommend solutions to workforce and talent shortages through collaboration with a number of different people in state and local government, higher ed, local workforce boards, and employers. But most importantly, I'm the mother of 4 children at Lake Oswego High School, 2 of whom are seniors and are off to college next year. So again, I'm Lori Cremona Wagner. I look forward to being a fierce advocate for our students, our workers, and our community as your elected board member at Portland Community College. And I thank you so much for your support.
Thanks, Lori. And now
Thanks,
I would
Veronica.
like to introduce
Board.
Dr. Karen Perez de Silva, who is running for a position on the Beaverton School Board. So Karen?
Hi, good evening, everybody. My name is Karen Perez de Silva. I go by the pronouns she, her, and ella. I'm a Latina mom in a blended family. I'm an experienced teacher, administrator, researcher, and doctor.
Okay.
And I'm getting here today. I've learned to use my lived
Did
and
they hear
cultural
me
wealth.
swearing?
Oh no, Lori, you're not muted. Thank
You
you.
need to turn your sound off, please.
That gets to all of us is Zoom, right? Turning on and off our sound. I'm an experienced teacher, administrator, and researcher and doctor. In getting here today, I've learned to use my life experiences and my cultural wealth to really as superpowers to help our community. I've experienced immigrating to the United States as a child. I am a multilingual English language learner. My first language is Spanish, and I'm also fluent in Portuguese. I've experienced elementary school as a special education student when teachers didn't know what to do with me when I came to the United States and had interrupted education. I've lived in situational poverty, and I've grown up in Oregon as a brown-skinned Latina. And I currently work as a leader for equity and systems improvement at Education Northwest. It's a nonprofit that supports districts and states in co-constructing more equitable educational systems and policies. I'm running for the Beaverton School Board Zone 2 because I want to use all this knowledge and life experiences to support and advocate for our students. First, I want to advocate for safe and culturally responsive schools. Second, I want to address the equity opportunity gap, or also known as the opportunity gap, with budgets and accountability measures. Currently, 10% of our Beaverton School District students are either not passing a class, they're failing or have incompletes, and what now? How are we going to hold ourselves accountable as a district to support our students? And third, I want to ensure that students and community voice is at the center of our decision making. At this time in history, more than ever, we need to step up for our students to ensure that their safety, equity, and opportunity allow them to thrive and not just survive in our schools. And one of the key pieces for me is that I want all students in the Beaverton School District to know that their race, their color, religion, gender identity, gender expression, sexual orientation, national origin, disability, and coming from a multilingual family are all really their superpowers. And they have the right to a high quality education, to experience belonging in our schools, and to really thrive. So I'll put my information there for everybody to go to our website. It's www.karenperezdasilva.com. And if there's any questions, let me know. Thank you.
Thank you very much. We really appreciate both you and Lori coming on and bringing us up to date on your races. We're very excited to have you running. I do
you,
have
Veronica.
a couple of announcements. On February 15th, the Oregon Historical Society is hosting a conversation with historian and professor of history, Heather Cox Richardson. She's the author of the daily Letters from an American blog, which many of you may have been reading. Among other areas, she is an expert on the history of the Republican Party, so her analysis is quite fascinating sometimes. I encourage you to go to the Historical Society website and sign up to attend via Zoom. Again, it's on February 15th, so Monday. Our March program, please join us on March 11th with Adam Davis, the co-founder of the Oregon Values and Beliefs Center, and John Schrag, the executive editor for the Pamplin Media Group. They will be taking a clear and hard look at the issues that divide Oregonians and explore effective responses to those divisions. Adam has been with us several times in the past and is always quite fascinating. And we're very excited to welcome John to our Zoom room. These are very challenging times. Please take care, stay safe. Sign up when you are able to get your COVID vaccination. And most of all, take a moment to thank elected officials at all levels who get up every day on behalf of we the people, as our Senator Jeff Merkley would say. As an aside remark from a friend, this is a wonderful time to write your senator or other senators to encourage them to have a backbone and please make the appropriate decision at the end of this impeachment trial so that we can send the very clear message that encouraging people to storm our Capitol and put our democracy at risk is not an acceptable response to losing an election. So thank you all for attending, and we will see you on Zoom next month.